Welcome to the recorded version of the Grantmakers and Aging web seminar, Who Cares for Older Adults? Workforce Implications of an Aging Population, featuring Richard Besdine, Greer Professor of Geriatric Medicine, Director of the Center for Gerontology and Healthcare Research, and Director of the Division of Geriatrics in the Department of Medicine at the Alpert Medical School of Brown University, and John Feather, CEO of Grantmakers and Aging, from May 31st, 2012. This event was made possible by a partnership between Grantmakers and Aging, the John A. Hartford Foundation, and the American Federation for Aging Research. Technical and production support is provided by the American Society on Aging.
Thank you, Steve. Great to have so many of you with us again today. Welcome again to Conversations with GIA. This is part of our continuing series of monthly webinars on critical topics of interest to funders in aging. As Steve said, my name is John Feather. I'm the CEO of Grantmakers and Aging, and I'm delighted that so many of you have joined us today to address the topic of creating the right workforce for our aging population. Before we get started, I'd like to ask you a couple questions. So if we could have the first question on the screen. The first question is, given the enormous demographic increase in older persons, the number of certified geriatricians continues to increase each year. And the answer is true or false. So please answer that question. All right. We'll go to the quick poll answers here. Most of you got this right. 97% of you said that the answer is false. In fact, as we will be talking about later, the number of geriatricians with certificates actually peaked in 1996 and has decreased ever since. Could we have the second question? Pharmacists have regular contact with older clients on a daily basis. What percentage of pharmacists are certified in geriatrics? And your choices are 1%, 5%, 20%, or 50%. All right, can we get the quick answer? The answer is actually 1%. Like medicine and almost all of the other health professions, we're lacking in individuals who have specialized training in meeting the needs of older persons. So with that, I want to begin our session today. Before I begin, I want to thank two of our members for their support in making today's webinar available free of charge to funders in aging. The John A. Hartford Foundation of New York is providing continuing support for the series, and the American Federation for Aging Research of New York is co-sponsoring this month's webinar. We also want to thank the expert team at the American Society on Aging for providing technical and production support for the series. In the past months, we have discussed aging policy issues at both the state and national levels. These recent debates in the media and policy circles about the future of healthcare have centered on the rising costs of care for an older patient population. Missing from the discussion is the capacity of our nation's doctors, nurses, social workers, pharmacists, and other healthcare professionals. With a lack of geriatric specialists available and precious little gero content in the traditional curriculum, this workforce is ill-prepared for the skyrocketing number of older patients with high rates of chronic conditions, multiple medications, and complex biopsychosocial needs. Our guest today is Richard W. Besdine, MD, who is Greer Professor of Geriatric Medicine and also Director of the Center for Gerontology and Healthcare Research and Director of the Division of Geriatrics in the Department of Medicine at the Alpert Medical School of Brown University. He is also Chief Medical Officer of the Federal Healthcare Financing Administration, which is now the Centers for Medicare and Medicaid Services.
Just from former Chief Medical Officer.
Former Chief Medical Officer, I'm sorry. From 1972 to 1986, Dr. Besdine served on the faculty of the Harvard Medical School and co-founded Harvard's Division on Aging with Dr. John Rowe. Welcome, Richard.
It's my great pleasure to participate, and I'm absolutely thrilled, John, to have access to these new friends in the audience and share my passion for good health and health care for older Americans.
Thanks very much. You will see that as we all know, there's going to be a avalanche coming in the future of healthcare, in the sense of more and more individuals with chronic care needs. Richard, let me start with this question. The medical system in the United States is in some sense the envy of the world, as evidenced by the number of people who come here for specialized care. And yet here you're saying that we have the wrong system for the 21st century. Why is that?
Well, several things. One, just to put a little levity in this, is one of our freshman congressmen earlier this year arguing against the Affordable Care Act said, "We have the best health care system in America," meaning the United States. So, yeah, I guess that may be true. However, the way it's designed isn't working. We have a healthcare system designed in the 1950s when most medical care that the population needed was for acute illness or injury. In the last 50 to 60 years, we have moved to a population more than 80% of whom need chronic disease care, or more than 80% of our expenditures are delivered for chronic disease care. And yet what we do is we sit in our hospitals, offices, and everywhere waiting for people to show up, and that doesn't work for chronic disease. There aren't sufficient incentives for coordination of care, which is critical to manage the increasing numbers of patients, and way more to come over the next 25 years, with multiple conditions, or as we call it now in the field, multimorbidity, as well as multiple medications and many, many providers of health care. We have a very well-trained workforce for 20th century health care needs, but insufficient preparation to care for the 21st century population. We have a shortage of scientists to find ways to improve care, a shortage of physician and other health professional teachers to translate that science into better care, a shortage of specialists in geriatrics in all the health disciplines, limited aging content in the curricula of most health professionals, and perhaps not the focus of today's conversation, but no needs-based system of care that will anticipate and prevent the clinical calamities that are inevitable for a population with multiple chronic illnesses.
Richard, you and I met when we both worked at the first two of the first four geriatric education centers in the country. You were at Harvard and I was at Buffalo at that point. That was back in 1984. And back then, we were sure that the huge surge in the aging population would inevitably lead to more and better training in geriatrics. We used to say demographics is destiny. Did that turn out to be true?
Well, as we all know, I think, sadly, no. The slide in front of you shows the number of active certified specialists in geriatric medicine in America since 1988, when we first began the certifying examination in geriatrics. Not only has the short-term growth not kept pace with population need, but there is absolutely no evidence that the current baby boom explosion into old age, or at least into 65, and by the way, we all know that's no longer old, but this explosion is not being met by any parallel increase in the number of certified specialists in any of the health professions.
That really seems like a tiny number compared to the population. What do we know about the ratio of geriatricians to this increasingly aging population?
Well, this slide's a little bit complicated, but if you look at this actual and projected beyond 2010 ratio of geriatricians per 10,000 population, I think that's over 65. No, 75. No. Oh, I see. It's by age, right. You'll see that it's worst of all for those who need expertise most, the over 85. And you can see that they've dropped severely, and also a decline not nearly as steep per population 75 and over, and so on. So it's not that we're killing geriatricians. It's simply that the population increases for those over 85 are most rapid of all, and as we've seen on the prior slide, we're not keeping pace by generating new physicians trained.
So we've talked about the lack of growth of geriatricians. Are the physicians who do have special training in geriatrics evenly distributed throughout the country?
Well, as you can see in this next slide, even in the sense of inadequate almost everywhere, but some places, as they say, are worser than others. You'll notice in the green there are only a few states that have, and this is geriatricians per 10,000 Americans over age 75. The average is 3.8. We estimate that an adequate ratio would be something north of 15 or 20 per 10,000 population. But even by this mean of 3.8, virtually every state is underpopulated. There is substantial variation, as many as almost 700 in California, but of course the population is huge. It just is painful to look at this as I think about population need.
Just thinking about, there are 9 geriatricians in the entire state of Wyoming. That's really amazing. But of course, we're focusing for this first part on geriatricians who are specialists, and that may be misleading. You and I often heard back in the day that geriatrics is best taught not as a specialty, but as an integrated part of the medical curriculum. Can you tell me that has happened?
Well, I'd love to, but first, please let me express my thanks for telling me what that square state kind of out there is. It's Wyoming. I'm not so good at geography. But coming to the main question here, it's certainly better than it was in the 1970s and 80s. Integration into mainstream curriculum is certainly a plausible strategy. The Hartford Foundation has made a huge investment in the development of faculty geriatricians, first in medicine and then in nursing and social work. And in parallel, the Reynolds Foundation has invested in curriculum on aging across the career span at 40 of the 134 American medical schools. And more primary care and specialty physicians are adequately prepared to care for older patients. But still, the numbers are absolutely inadequate today and are going to be made even less adequate by the rapid increase in the number of older Americans and the number of very old Americans needing care. If we don't ramp up our career development programs, things will get a lot worse. And by worse, I mean more fragmented care, less anticipatory care, and with less anticipatory care, a lot more of the clinical catastrophes that we all know and hate: falls, aspiration, pneumonia, strokes, heart attacks, amputations from diabetes. You name it, it will happen, and it'll happen here.
Well, that's certainly not very encouraging as we move to the next slide. But in some ways, physicians are a special case. Go ahead.
Sorry, I missed going through the specialties and curriculum. You can read the numbers back on that prior slide about how inadequate, in spite of the Hartford and Reynolds initiatives and others as well, how inadequate the preparation of mainstream medicine is regarding care of the elderly. And, of course, every one of the subspecialties, dermatology, emergency medicine, physical medicine, subspecialties of surgery, neurology, etc., all of these have certification examinations for pediatrics, different from adults. And I would argue very loudly the same should be true in geriatrics.
And yet it's not. So as we move to the next slide, we talk about that, as I say, physicians are somewhat different, and that they're not the ones who usually are doing the day-to-day care of older persons. I'm hoping that nursing is better. Would I be correct in that?
Well, first off, no single profession can manage health needs of an aging population alone, but certainly nursing is no better than medicine. Fewer than 1% of RNs are certified in geriatrics. Less than a third of baccalaureate programs have even one faculty member certified in geriatrics. Fewer than half of nursing schools reported having any full-time faculty. A third reported having part-time faculty. So it's not a good story throughout the profession of nursing.
Nurse practitioners and certified nurse specialists are in some ways analogous to geriatricians in that they have specialized training and certification on their knowledge. You touched on this a little bit, but are we increasing those numbers?
Well, sadly, it's even worse. You can see that there is absolutely no evidence of increases commensurate with population growth of older Americans.
Right. And as we move to the next slide, and you'll probably start seeing a pattern here, we see that gerontological social work, which has had a very long and proud history and in many ways has been a pioneer in the field of aging, and many of the leaders in aging have come from this background. Is social work leading the way in its training?
The monotonous and perhaps disheartening beat goes on. Almost half of graduate schools in social work have any faculty in aging. 80% of bachelor's programs have no coursework. 1 in 8 social workers identify aging as their practice area, and yet 75% of social workers reporting working with older adults, tiny proportions have had any courses in gerontology. Fewer than a third of schools of social work offer specialization, and only 5% of MSW social workers specialize in aging.
If we go to the next slide, maybe we need some psychologists to help us with the depression we're going to have here, but is the same true for psychologists?
Yep. The numbers are on the slides. In psychology, it's kind of almost a little bit poignant. They are almost all of them are providing services to older adults, and they perceive they need training, and they acknowledge they don't have it. So maybe they need treatment for depression also.
And our next slide is, we could probably go through every single profession, but this one is for pharmacists. For many years, I was part of the organization that certifies pharmacists who have special skills in geriatrics. In some ways, pharmacists are an interesting healthcare profession in that they have a lot of interaction with older people outside of the clinical setting, particularly those who work in retail pharmacy. And we would certainly hope they would be doing better. But as you see here, unfortunately, we know that's not true either.
Yeah, that first bullet on the slide, fewer than 1% certified in geriatrics, it's just excruciating because I think, as everybody knows, medication adherence and adverse drug reactions cluster heavily in older patients. That's in part because who's taking the drugs? The people with the most chronic diseases, and these are older people. Now, again, some of the most exciting leadership in the field of aging has come out of the discipline of pharmacy, both pharmacists and doctors of pharmacy, but they are such a drop in the bucket when you look at the entire profession, it really does get discouraging.
So we'll turn to one last profession on the next slide, and this is direct care workers. All of these healthcare professionals obviously have a long way to go in training, but especially as we try to increase the services provided in the community rather than healthcare institutional settings, we know that most of the hands-on care is provided by those without extensive professional training. How are they doing?
Well, great strides have been made in the mandatory minimum education standards for certified nursing assistants who work in nursing homes. 75 classroom hours, another 20 of practical hours, but it's not enough, and wages make the numbers of certified nursing assistants in nursing homes inadequate, so in some ways this may be the worst story of all. Having talked about this substantial investment in training of CNAs, their turnover is huge. At the end of a year, most of the people are gone, and by 2 years, they're all gone. Turnover. So the cost of training and new cohorts is just huge. And by the way, this last bullet makes me cringe because for most of us, there is a nursing home in our futures if we live past the age of 65 or 70. Federal training minimums for direct care workers haven't changed in decades, and they're lower than dog groomers, cosmetologists, and crossing guards for school children. I mean, I can hardly believe it.
Right. Well, let's now turn to what we're going to do about this. And before I do that, I want to remind our audience that your questions will be the focus of the last part of our discussion today. So please type in your questions in the box that's shown there on your screen, and we'll be moving to those after we finish up on the presentation. And hopefully some more encouraging things. What do we need? That means in some settings, every single direct care worker you meet will be gone by next year, as you say, and that's just amazing, but we've all seen that. But what do we need to do? We've outlined the challenges. What do we do? What do we need to do, and what can we do going forward to meet the needs of older persons?
Well, I think it's a two-pronged effort. The first is to build, launch, support, and improve a rational, needs-driven system of health care for our country that includes, part two, the second prong, adequate education in the principles and practice of geriatrics for all health professionals who are, pay special attention to my word here, all health professionals who are allowed to care for older Americans. And that may sound a little bit aggressive, and I mean it to be aggressive. Having been an executive in the Medicare program back in the 1990s, I argued unsuccessfully that the practice of paying all providers for services delivered to Medicare beneficiaries was outrageously stupid. We should only be paying for providers who demonstrate, either by certification or practice, the ability to deliver adequate care to older people. So anyway, that's my rant for today.
Well, I hope there's more to come. Since we're talking to an audience of Grantmakers, I want us to focus as we draw the presentation part of our session today to a close. I want us to focus on what Grantmakers can do.
So there's a huge amount that Grantmakers can do. I've talked about two of the leading foundations already. We need more fellowships for faculty in all of the health professions. Geriatric medicine, geriatric nursing, and geriatric social work probably in the lead, but pharmacy needs to be included. And when you think about the critical role of therapists of all kinds, dentists, there are a lot of health professions that older people need to remain both literally and figuratively on their feet. I think grants to conduct research to improve care of older people, but also funding for the teaching that needs to be done, again, to translate that research knowledge into the care delivery system. Endowed chairs are wonderful. I've been privileged to hold an endowed chair at the universities where I've been since the 1980s. And what it does is it frees the professor to allocate time to those things that are most beneficial to the population as opposed to covering salary. Lectureships, especially at places that don't have the rich faculty resources that the leading academic centers that have aging programs. Funding travel for those who want to enhance their knowledge, their practice knowledge, to scientific educational meetings, and of course improving geriatrics curriculum in all the professions, and innovative continuing education, certainly for current practitioners. But let me be very clear. I don't expect or want there to be enough expert geriatricians, physicians, nurses, social workers, and other professions to take over care for all older Americans. Quite the contrary. The population needing geriatricians is barely 5% of older Americans, the most frail with the most multimorbidity and medications. But for everyone else, they need health professionals with adequate education and training in geriatrics, so that the dominant need is for faculty in each of the professions to teach in the educational mainstream of that profession, but teach those people who will never be geriatricians.
Thanks. As we move to the next slide, we're also continuing on the notion of what funders can do. Some funders are involved in policy work on aging rather than education and training. Is there a role for them as well?
Absolutely. My own current work is now heavily involved in research to inform healthcare policy and advocacy based on results of such research. So funding policy-relevant research, convening expert groups, commissioning reports, providing resources for federal and state legislators about the key issues, about Medicare and Medicaid payments for care of older people, for education, for research, loan forgiveness for those who do choose to specialize in geriatrics regardless of their profession, federal and state funding for geriatrics education, especially considering the current potential crisis regarding the financing of graduate medical education, which pays for residents and interns and fellows in the medical subspecialties. That funding is in the crosshairs of budget-reducing shotguns wielded in the Congress, and I think we have to be strong advocates that we need to continue preparing our workforce for care for older people.
We can go to the next slide. I want to remind the audience that we are coming to the end of the presentation part of the event, and we want to make sure that we have your questions for the next part of our conversation. So in addition to policy and other kinds of work that many of our funders do, actually a majority of our Grantmakers and Aging members work exclusively in one geographic location. So obviously they're not going to be looking at national program funding. Is there something that they can do?
You bet. Implementing high-priority national programs that are both missing in their local environments and are likely to be useful in the local environment. So a few examples. There are hospital-based clinical programs that certainly are not purchased or implemented in most hospitals in America. The niche program, and that stands for Nurses Improving Care for Health System Elders. It's a wonderful nursing program. The two teaching hospitals in which I spend most of my time here in Rhode Island both happen to purchase that program and use it, but it's not cheap. And there can, I'm a big advocate of not letting the perfect be the enemy of the good. There are elements of niche that are relatively easy to implement. So another acronym, the ACE program, Acute Care of the Elderly. This is a redesign, both physically and workflow, of care for old people in the hospital, involving getting them out of bed every day if they can, walking them if they can, letting them sleep through the night. There's a radical idea while they're in the hospital, so they're less likely to get delirious. Another acronym, HELP, or the Hospital Elder Life Program, developed at Yale. Again, a way to maximize good outcomes and reduce complications for hospitalized older people. The Chief Resident Immersion Training Program, or CRIT, is a wonderful grant program, again supported by Hartford and Hearst and I think another foundation. Chief residents are the residents in their last year who are the most advanced and do a huge amount of teaching of the residents and interns below them. So this program gives them geriatrics expertise and also leadership skills. And actually, we here at Brown got that grant just this year, and we did it last year with our own resources because we thought it was so valuable. There are geriatric co-management programs in which an interdisciplinary team of geriatrics competent physician, nurse practitioner, social worker get together and help provide care for the most vulnerable older people in and out of hospitals cared for by other specialties, orthopedics, general surgery, trauma surgery, mental illness, cardiology, diabetes. Examples abound and can be easily developed at the local level. And finally, career development training programs. National models are another acronym, MSTAR, Medical Student Training and Aging Research. This is to support medical students in that only summer they have off between first and second year. Most of them do something related to medicine. This MSTAR program, administered by a FAR and funded broadly, first of all by Hartford, trains medical students in aging research and gives them an exposure to geriatrics. The Beeson program, funding advanced fellows and junior faculty geriatricians to conduct research and launch their research careers. The Hartford programs I've already talked about, community college programs. There's just a huge amount that can be done at the local level, and I would urge those of you who are not in geographic areas that have the kind of richness that we're blessed with here at Brown to find someone to partner with who's related to the care system and can help you identify what the highest local priorities are.
Thank you. That's really wonderful advice. We're now ready to turn to our questions, and I'm actually going to ask you two as we get started, and then move to our questions from the audience. Once again, a reminder that you can type in your questions into the box, and I'll be reading those to Richard, and he'll be responding. But Richard, this is a question that I've certainly pondered on a lot, given that both of us have been in the field for a long time. We knew literally 50 years ago that the baby boom was coming. And as I say, back in the 70s and 80s, we thought that this would inevitably lead to a rapid ramp up in the both professional and other individuals who work in this field, and that didn't happen. Do you have any thoughts about why it is that we're now facing this change and this tremendous increase without the folks that we need?
So that's kind of the $64 trillion question, which is what healthcare is going to cost over the next 15 years if we don't change the paradigm. I had a T-shirt back when you and I were working in geriatric education centers from the Gerontological Society of America, and it said GSA on the front, and on the back it said, "Aging ain't for sissies." Getting older has some negative features to it. I think most of the world, both professional and the lay public, imagine aging to be much worse than it is because they attribute everything bad that happens in old age to aging. It turns out if you learn the biology of aging and physiology, most of what is due exclusively to aging is rather modest. But I think it is that everybody is kind of afraid of aging and runs away from it. Bob Butler called it ageism in his now legendary Pulitzer Prize-winning book way back in the 20th century. But I think it's alive and well, but more important for present times, it's a vicious and insidious disincentive to do what we need to do, which is to get about the business of having all the health professions understand aging and be able to manage it along with the aging person and her family optimally.
Well, here's a follow-up question to that. Is it too late? Did we miss the window of opportunity, and now we're just going to have to make do with the system that we've got as best we can?
No, of course not. I think the window of opportunity, as you say, has been open since the end of the baby boom in 1964. We haven't quite been realistic about how many of those goddamn babies born, 80 million of them, would survive to be eligible for Medicare or survive to need other services. And so we're caught short. But we knew about this increase in survival and heartening, for the most part, decrease in mortality for the last 25 years. The window is still open. I think it's going to slam shut on our fingers and maybe on our necks over the next decade. I think we've got 3, 4, or 5 years now where bold action to incentivize the kind of anticipatory care I've been talking about and penalize the kind of delayed passive care that results in these catastrophic bad events that are very expensive, disabling, and discouraging for older people. But we don't have a lot of time to get moving.
Amen to that. Absolutely agree with you on all those. Here's a more specific question. What specific knowledge in geriatrics is most useful? Is it only biological and metabolic issues, or social issues that affect lifestyle habits and cognitive abilities? And let me put that a slightly different way, which is, what's the kind of percentage of chronic illness and so forth that may be caused by the biologic metabolic issues on one side and lifestyle habits on the other?
What a great question. I addressed that question in a lecture I gave last fall in Italy, not in the United States, pointing out what the data tell us, and that is of preventable, meaning amenable to health care intervention, causes of death in the world, and America even more so, more than half of the interventions are behavioral to reduce mortality. So it's not necessarily a psychological intervention, but it's getting people on their own to do what's good for them. So it's stopping smoking, exercise, diet, and in collaboration with your healthcare providers, addressing blood pressure, blood sugar, the kinds of diseases that or conditions that, if unaddressed, lead to these catastrophic outcomes. In addition, there are data showing, for example, that in people with heart attacks, those with depression superimposed have double the mortality. And still in America, just to not go on endlessly about this, but still in America, half the deaths annually are attributable to cigarette smoking. Half the deaths, whether it's due to cancers, chronic lung disease, or cardiovascular disease, all of which are greatly made more likely by tobacco.
And I believe tomorrow is actually World Tobacco-Free Day, if I read my headlines correctly today.
Yes, indeed.
Yeah. So let me ask you a question about the focus, because you mentioned it a little bit, but we've discussed primarily educational needs today and the preparation of healthcare and other professionals to serve an aging population. But what else needs to be done to do that? Obviously, we can do all the curriculum change we want, and we can't make it work if we don't have a healthcare system that supports the things that we're training students to do. So what do you think are the primary issues we should be addressing there?
Well, I've alluded to this already, and it's as I say, it's the second prong of what has to be a two-tined fork to help us solve this enormous looming and currently occurring concern about health care for older Americans. Right now, we wait in all our world-class health care institutions and offices for people to show up with complaints. That's the very foundation of health care in America. I don't call that a system. I call it an apparatus. A system would mean to me that you look at the needs of the population and you design delivery to meet those needs. After all, what is the first question the doctor asks you when you show up or when you make an appointment? What is your complaint? The trouble with chronic diseases is that for most of the time that a person has one, there is no complaint. And by the time they have a complaint, the horse is usually out of the barn. Now, I don't mean that everybody with a chronic disease dies the day they get the first symptom. But what I do mean is that by the time symptoms occur, those diseases are so far advanced that the interventions are only, at best, palliative or delaying. So we need a system of health care in which there is routine surveillance, case finding, looking for risk factors for chronic disease as well as evidence of very early onset chronic disease, and interventions at that point are less expensive, more powerful, and more likely to keep people functionally independent, which is, of course, what we all want for ourselves.
The next question is about the general issue, the general topic of pay for performance. Of course, this has been discussed a lot over many, many years, and you talked about it in a different context already a little bit in terms of should we have people that have evidence of knowledge or training in serving this population. What do you make of the various efforts around linking payments to outcomes?
It's a great question also, John. You look at the face validity of only paying for good outcomes, and certainly if someone builds you a garage and forgets to put a door on it, you're not going to pay them. So there's huge face validity. The operationalizing thus far, every pay-for-performance experiment that the Medicare program has funded has essentially failed. The only people who improve when you offer an incentive are the ones who are already the highest performers, and it's the rich get richer and the poor get nothing. So what I would say is the idea is sound. We haven't figured out a way to operationalize it, and certainly it's not ready for prime time. I think that's enough.
I think there's certainly continuing and growing interest in this area, but as you say, it's a complex one. It was involved to some degree in the field of pharmacy around these issues, and the measurement questions are enormously complicated. Try to do this reasonably. We're coming to the end of our time today, but I wanted to make sure that we had an opportunity for you to give us your thoughts, particularly around other things that you would like to see. If you could walk into any foundation in America and say, here's what we need, what are the top three things that you would say?
Money, money, money.
They get that fairly often, so I'm not sure that's the right one.
There are so many things that need doing. I think one can't afford to start with just one, so I'm not going to put them in a priority order. I think we need more demonstration of how to link science and education in healthcare. In other words, the NIH funds $32 billion of research annually. A lot of that research is directly pertinent to diseases, common chronic diseases. And yet, it takes, on average, a decade for something proven scientifically valid to get into a standard of care. So that's one area that I think is crucial. And whether I spend my second quarter on a linked area or try to get it under the tent of number one, we don't really have adequate career path funding for people who are going to be expert teachers in medicine. Historically, we've cross-subsidized the salaries of those people from all the profit in delivery of clinical health care, and those monies have dried up. So I think recognizing the validity and importance of a generation of teachers in medicine who will be part of this translation effort. We always need more research, but I think the research dollars I would advocate for are dollars that in the downstream delivery of health care demonstrate optimal ways to improve outcomes with older patients. And again, I think the Centers for Medicare and Medicaid Innovation have $10 billion in the Affordable Care Act to do that. Whether that's going to work at the local level is to be determined by the outcomes. I think the third arena has to be policy. Right now, every decision we make in healthcare, we try to make on the basis of good clinical evidence. You may have heard the term evidence-based healthcare. If you've ever been to a session of Congress or testified before a congressional hearing or briefing, you know that the way the Congress makes laws is not on the basis of scientific evidence. It's either by lobbying, either the kind of lobbying we all deplore, of junkets to Paradise Islands, or the kind of lobbying that is defensible but still not the way to make laws, and that is by clinical stories of either good or bad outcomes for individuals. So in the policy arena, I would like to see more participation by healthcare providers who either have produced or mastered the evidence base to help the Congress make wiser decisions.
Wonderful suggestions all around. Richard, I want to thank you for participating today, and keep up all your wonderful work that you've devoted your career to.
Thanks, and this has been a wonderful opportunity for me, and I would urge regular, frequent conversations for Grantmakers in Aging to work with leadership in the health professions to keep each other informed.
We will certainly be doing that. And once again, I want to thank Dr. Richard W. Besdine, the Greer Professor of Geriatric Medicine at the Alpert Medical School of Brown University. We thank you, Richard, for everything you do to make life better for our nation's older adults. I also want to thank the John A. Hartford Foundation and the American Federation for Aging Research for their support of this program, and as well as the American Society on Aging for their technical expertise. In the next 6 weeks, we will actually have two conversations with GIA, and I want to bring both of those to your attention. The first takes place on June the 28th with the work of the Diverse Elders Coalition, talking about the increasing diversity in our aging population and how various groups in the country are working hard to meet those needs. And 1 week later, on July the 2nd, Assistant Secretary for Aging Kathy Greenlee, will be talking to us about the recent changes at the Administration on Aging to link aging and disability issues. Please watch your email for more information on both of these presentations. Remember that we need your suggestions for future topics and speakers for conversations with GIA, so please send us your ideas. And finally, I want to thank all of you for participating in today's webinar. Have a great day.